The event log, I would say, remember that you can pick and choose what to add to it when you upload your monitor. A lot of times I QC your charts and I see like vitals, and 4 of those vitals are just SpO2s or CO2s.
The diastolic is higher than the systolic.
Or your diastolic is higher than your systolic. When you upload those...
bradycardic to 13, but 3 minutes later, they're totally normal at 60.
Sure.
They're at 130.
Yeah.
When you choose to upload it, uncheck the ones that we don't need. And then once you upload them or before you upload them, look at them before you upload them, because a lot of times I think I'm QCing charts that we're just uploading the monitor and then you're hitting OK.
And that's routine across every agency I have ever reviewed in the past 5 years that we've had that feature. Is it gets abused. You import everything, you don't review them. So I think it's really important to make sure everyone knows how to get to the print preview section of Health EMS ePCR, because when you look in the event log, you can't see all of the vital signs. They're not all listed there. So in the top right-hand corner, the 3 dashed lines, you click on that. Then there's a print preview button. It's going to open up in a new tab and give you your full PCR the way that your medical director is going to read it.
The way it's going to print. I'm going to use that.
Yeah, exactly. Anyone who's going to read that chart once you export it is going to read it in that view, not the view in the way that you document the call. So that's where you're going to be able to see your list of all the vital signs and trending, so you can throw out those outliers because the patient was, trying to sign the tablet or, waving somebody down behind the squad. I don't know what they're doing, moving their arm around when their blood pressure gets all messed up. So make sure they go back and quality control their own.
They were texting their boo.
Most likely texting someone to tell them, oh, you would not believe what happened. I'm on my way to the hospital.
My current situation.
Yeah. I love to get behind them.
Live stream.
Yeah.
So.
Unfortunately, though, once you submit it, it's part of the patient report. You can always go back and you have a certain amount of time to fix things, but if it's not caught, you will have a pressure of 168 over 148 and then 4 more at 168 over 84.
Right.
So obviously it's pretty obvious to us when we QC what happened, but again, if that goes to court or somewhere else, they might ask, well, what did you do about this? So keep an eye out for it.
And you're using what, in my opinion, is the low-hanging fruit here. Everybody, this really doesn't even need to be said. Everybody has pushed the button, got a set of numbers, and they're like, that is complete and utter bullshit. And they push it again. But that first set that you mentally dismissed, right? It's almost exclusively the blood pressure, and we know that just because of what the machine is doing. It's reading a map, and then it's
guesstimating the blood pressure.
Calculating, we'll use in air quotes there. It's guesstimating the systolic and diastolic. Everybody at this point should know that. We've been very loud about that in our QA or in our CE for the last several years. You should be highly suspicious of every single blood pressure, and just go back, read that, make the edit like you're talking about, or delete it outright.
What you guys don't actually see when I bring up that multiple people review these reports, I'm having current fights now where if a patient comes in and we think that let's say they've got a fever, we suspect a urinary tract infection, we all know what sepsis is, right? No. Sepsis, I would certainly hope you know what sepsis is. Okay. So if patient meet certain criteria, they trigger sepsis, and we worry about mortality in these patients, and we want timely intervention, specifically antibiotics, and especially fluid resuscitation. So if we are documenting the patient has these sepsis criteria and you throw in an outlier of 89 over 40 of a blood pressure, they now trigger into severe sepsis. Yeah. If you don't finish your report until 23 hours later, I don't see that.
And you've already started ceftriaxone or something.
Well, I've already started my resuscitation, but you have that one outlying blood pressure. I never see it in the emergency department. I don't consider severe sepsis because I don't know that it's there. I don't appropriately fluid resuscitate. We don't meet our requirements for the appropriate care of a septic patient because they now meet septic shock. I did not give enough fluids to meet septic shock, and now we have a sepsis fallout from the inpatient side because a erroneous level was included into the report. So that's a longer report, and that doesn't matter to your care of a patient, but if we're talking about being patient advocates and getting good care for these patients across the spectrum, whether that's pre-hospital, ED, hospitalization, ICU, whatever that higher level of care is, it's very important from that standpoint.
Or on the other side of that is we don't document pre-post vitals in our intervention,
yeah.
and we've started that exact same resuscitation you're doing.
Yeah.
Maybe we acted solely on, they lost radial pulses, we squeezed a liter in, but the initial blood pressure was okay, the ending blood pressure was okay. We did a lot of heavy lift in between,
yeah.
and you didn't know it,
Correct.
and then you unintentionally softball that patient.
Yeah.
There's wide implication from that.
And let's say you don't even document that leader because you're so busy you just forget to do it, then that leader could help us in our resuscitation too. To say that we met our fluid requirements for that patient.
Absolutely.
Or I'm going to let's say that they did drop their blood pressures. You guys gave your liter of fluid to help improve those blood pressures, but they also have heart failure. Now I am forgetting it. I don't know about a liter of fluid that was given to this patient. I can then over-resuscitate them, overload them with fluid, and now we're playing that game of too much fluid on board.
What's going to kill him first?
I got to give him fluid and take it off at the same time.
At the same time, right?
Yep. And then that could send the patient to a different level of care in the hospital that might end up in the ICU because we over-resuscitated them versus nope, they're stable for like more of a step-down unit, a transitional care unit that doesn't need the ICU level of care.
I think we need to remember, too, some of our tools don't import, blood glucose especially. If we're doing blood glucoses, we need to manually import those, and they are very critical that we import those into health EMS especially.
I would argue it's the fifth vital sign.
I agree. That capnography.
Yep, sixth vital sign.
But they don't manually import, so we have to type in those numbers. And if you're just exporting and importing your monitor after, beforehand, we're not going to catch that. And I do see a lot of charts that I review that don't have sugars. They say blood sugar was obtained, but there's no numbers given. And that
I would argue it wasn't taken.
Exactly. And I guess where I'm going with that is recently.
Would argue it was not taken.
Yeah, if it's not documented, it didn't happen.
Correct.
I can tell you I was on a call recently where our crew responded and we ended up taking an airway because this patient had vomited in bed. Obviously, the squad crew did BLS before ALS, and we rolled the patient, cleared the airway, got him out to our ambulance where we took the airway from them and deep suctioned a bunch of food out. Well, it went because the ketamine was administered to the med review, and one of the takeaways was, you guys should have cleared the airway before with BLS skills before you even transferred it. Well, no kidding, we did, but it wasn't documented. They're exactly right. It didn't happen. And we can sit there as a squad crew and say it was done. It was done.
Yep.
Wasn't on the report. So they're absolutely right. And so that's a good takeaway for even me to say, I got to make sure this gets in next time. So if it didn't document, it didn't happen.
And most of the things that we're talking about, it's just a single sentence.
Yep.
Airway was cleared.
Airway was cleared prior to removal.
Yep. Exactly.
And it would have been handled and done, but they're exactly right.
And you probably don't have to say a patient was rolled and did this. Airway was cleared.
Which leads me to a question for John here is, how much time do I have after I hit that submit that I can go back and add an addendum to my chart and say, oh, you know what, actually this happened?
Well, like I said, your documentation is your documentation. You signed it. You own it.
Right.
You're the one that wrote it. So at any time after you export the call, right, that is the first record that gets sent. It immediately goes to the hospital. It, within the week, will go down to the state. It goes to billing within the week. So that is your first record. However, if you ever need to edit anything, it is your document. You can log into Health EMS Manager and change any of the documents that you have authored. On top of that, if you just want to make it easy, you can also call your administrator on your department or myself. We can always send the call back to you in Mobile Touch. There's two different ways to do it. You can go into Health EMS Manager, edit yourself, or you can have it sent back to you in Mobile Touch so it's back on your device that you're used to documenting.
Is that time stamped?
Oh, absolutely. Everything is tracked. So from the time you export that record, everything it's done, if it's anything is edited after that or even viewed. So if I look at that report after you've exported it, I have to run an audit trail and show who all's looked at it and what's been changed, what it was originally, what it was changed to, with a date and a time. So we have a very good tracking process on all of that. But if you need to document something, you need to change something, you forgot to add something. I tell you, you put oxygen on a ton of patients, or at least we used to. Sure. I would constantly forget to say that, I threw them on 4 liters nasal cannula, and I'd constantly have to go back and edit that.
And when you do an addendum, it forces a dialog box, reason for resubmission or something to that effect, and you have to actually put in there.
And try not to just put comments.
Reasons. Explain. I forgot.
Give a reason. This was an addendum due to, forgot to add.
Yeah, absolutely.
Forgot to add this, that, or the other.
I forgot to add the patient's name. 12 leads. When I
my
take 12
goodness.
leads in and I add 12 leads, there is a box that says manual interpretation. If I'm going to manually interpret something, I better make sure I get it right.
You should always manually interpret your
Always.
EKGs as a paramedic.
As a paramedic.
Do not rely on the computer interpretation
Thank you.
of the EKG. It is wrong.
9 times out of 10, we're smarter than the machine. The machine is set to such specific parameters, we might catch things that it just doesn't.
You will catch things that it does.
Absolutely, that's a better word for it. Read the EKG, though. Take the time and read it, and don't read what it says on top.
Correct.
It's not right. It's not right. So make it a habit when I teach the medic classes, cover that. Don't even look at that. Cover that up. Don't look at that. And then read the EKG.
Yep. And if you have a question about it, transmit and discuss with med control. You say, hey, I have a concern about this lead. I see this. What do you see? I'll say, yes, I agree with you, or no, I don't, and maybe we can get some education on the phone. We can even talk about it when you bring the patient in.
Doc, I have an LVAD patient that just looks really weird. Can you tell me what this looks like to you?
Transport. Is the pump making noise?
Does he have a systolic pressure?
Are there any red lights
Yes.
on the box?
Is there an alarm? That's a whole nother discussion.
There are some evil administrators in the world that turn off the interpretation on their
That's
cardiac
not
monitors.
a bad theory.
So we have on most of our EKGs in the emergency department, the interpretation's turned off. So the only thing you'll get on the interpretation is going to be your interval measurements or your heart rates.
Which is such a great tool to use because those are very specific.
Yep.
You don't need to grab your calipers per se. It's right there. So why are we not using those more?
So that's the only thing that I look at those. I look at my intervals. That's all I really use the top of those EKGs for. But I also verify that they make sense with what I'm seeing on the EKG.
Absolutely.
If I think, oh, that's a prolonged QTC, what's the measurement say? Oh, it says 300. That's not a 300. So,
But to your point, we do have medications that require us to look at that prolonged
Correct.
QTC, and everybody at first was, oh, I can't find it. It's right there.
yep,
Right there. Read your EKG. It's right there.
It's right next to the words you're reading already to base your decision on what you're supposed to do.
This is also 2022, and at the time of this recording, this might be 23 when it's getting aired. But the point I wanted to make was I am pretty good at interpreting 12 leads.
No, you're okay.
Pretty good. But do I know every symptom? Do I know every pattern? I simply don't, right? I'm not a cardiologist, and it's okay to ask for help.
Absolutely.
Right?
Absolutely.
And, we can send that stuff ahead. There's been several times like, ooh, this is suspicious, but I'm not entirely sure. Get a second opinion, right? Send that to medical control.
So
And even better, document that in your narrative. Like,
correct.
reviewed EKG, discussed with Dr. So-and-so on the phone about this. And they gave either recommendations or no recommendations.
Right.
Towards the end of last year's class, one of the students came to me and said, look at this EKG. Tell me what you see. Sinus tachycardia.
Yeah.
No, there's S1Q3T3. I'm like, kudos to you to recognize that.
Oh, I remember that, yeah.
But what are you diagnosing here? Well, they have a PE. I go, what's the first step of looking at an EKG if you suspect they have a PE? Well, S1Q3T3. No, it's tachycardia. So it's like, oh.
What is it, like 4% or something? It's
25% of, so people with PEs, 25% of the time will have S1Q3T3.
Is it S1QT3T or evidence of right ventricular strain?
It's S1Q3T3 for 25%, to be specific, yeah.
So still not a slam dunk.
As a paramedic, if I see tachycardia with chest pain or absent lung cells, I'm thinking PE.
But even the stories tend to be way more precise.
Yeah, the story, the blood pressure, the
Exactly.
hypoxia.
And going back to the narrative,
febrile.
called for chest pain on a 30-year-old patient who just had surgery last week and now has acute onset shortness of breath. Sets the scene for what you're going to be looking at.
Absolutely. Just had drove a car from Florida to Ohio.
Yep.
So I think it's important to really talk about that beginning picture of the narrative, right? So I always drill down on history of present illness. That has to be the first thing. And generally, it's where I got dispatched from, how I showed up, right? And then exactly what I saw when I walked in. And then I want to make sure when I write my narrative that when you read it, you can see that patient sitting in front of me, diaphoretic, skin color, how are they... Are they
Tripod
able to
position,
talk in full
Yes.
full sentences? All those things. That, to me, is one of the most valuable things in my narrative, that in the first 3 or 4 sentences, I want to know that when he reads it, he knows what that patient looked like. And then I try to tease out history of present illness, how they got to that point. So those are my first couple of sentences in every single narrative because I want him to know what that looked like. And then I try to describe it again before we drop
to your
them off.
point, when I QC reports, the first couple sentences I read, I'm like, this is a bad one or this is a good one.
Absolutely.
And if you can determine that, then you've written a good report probably.
My third sentence in my template is how the patient looked, which is different. Like I call for shortness of breath, walk in and find a patient tripoding, audibly wheezing from the door, in distress is different than got called for shortness of breath, sitting comfortably in her chair, no
talking to me in full sentences.
Talking in full sentences versus lying in bed, agonal breathing, sweaty, diaphoretic, thready pulse. That sends a very different picture.
In a lot of ways, I hate the fact that we use a pediatric assessment triangle for pediatrics only. This should be utilized the same way for adults in a lot of cases. You can do a doorway exam and say that I have a sick or not sick patient before I lay hands on the patient most of the time.
I wrote the scenarios for, was it this year or last year's protocol? It doesn't matter. I wrote the scenarios and I cut a bunch of flack for my description in there of, I said the patient was Crayola gray.
Oh, yeah, I remember that.
Right?
But we all knew exactly where you went with that.
I caught a lot of flack for that. And I said, but, think about that. You've walked in and from the doorway been like, oh, this is bad.
Yeah.
I think that's one of the biggest shortcomings I see in narrative writing is that they're not able to really depict what that patient looks like. That is the one thing that I think that every single clinician can improve upon is I know we use it and we overuse it, the painting of the picture of the scene or the patient. But I think that's where we really can drill down and improve.
I agree. Part of that, too, I think that when trending things that we do at UH and you guys do, there's the chief complaint and then there's the primary impression. And the primary impression really is looking to what did the provider treat? Why did you treat it? Now I want to know why in your narrative and your event log. But we should be, and when I QC reports, I look at the chief complaint, then I see what was the primary impression because that's the medic's guess. That's our differential diagnosis. But if you see that the primary impression was change of mental and the narrative and the event log doesn't follow that, we have problems.
Right. It's important to note that in Health EMS that the pick list that you have for chief complaint is not finite. You can type whatever you want in that box. And I usually, when I teach anything about documentation, I say, hey, excuse me, sir, why did you call 911 today? The next thing that comes out of his mouth, that is his chief complaint. I'm going to put that right in quotation marks.
And a lot of people want to put the dispatch chief complaint, but they have a situation where they're kind of limited on their chief complaints. It's not the patient's chief complaint. And like you said, just the other day, I was talking to somebody and they I didn't know you could do that. Oh, you can type whatever you want in that first box. Now the primary impression is a little different, but
building off that, we had a case recently. Chief complaint was bilateral leg pain, right? Provider impression number one, congestive heart failure. They were so full, it was all dependent edema that was really causing. And then what did we treat? We treated congestive heart failure, but that's where that difference, or an example of that difference, right?
I think what we didn't talk about so much, and it's even more important in some cases that we get the documentation correct, or sign-offs. I hate doing sign-offs.
Highest risk.
I hate them.
Procedure you guys are going to do.
Some departments out there might say that they have signed off Sundays. No, let's not do that. Sign off, like you said.
Browns jersey. Oh, you're feeling better, son. Here.
My documentation is usually at its best, and it's always good, don't get me wrong, but I triple check before I submit a sign-off. And if we're not able to get vitals, that's shame on us. We should be able to get vitals.
You should definitely document why you were unable.
Document
patient
why you
absolutely
couldn't.
refusing to allow us to evaluate.
Explain to the patient the risks of signing off, and that you need to seek medical consult. You need to call us back, and all too often you get a patient refuse sign off obtain.
That's not enough.
It's not enough. And when this patient decides to sue you a month later because their neck still hurts, guess who's in trouble now?
Or a patient signed off and then you find out they went into cardiac arrest later.
Not good. That's not good. So we definitely need to be double checking those. Have your partner go over it with you. They're just as liable, and people don't realize that either. Your partner in the EMS squad is just as liable, even though you submitted that chart. They're still attached to it. They're still part of the crew.
Absolutely. So going back to what we should be in the narrative, I think that we touched on it before, very situationally dependent. So if this is a trauma, we're going to document different things than we document with chest pain. Different than shortness of breath, different than leg swelling, right? So what I think we need to do is thinking about those specific instances, like when we're talking about traumas, there's things that I want to see in that report. If they have a wound, I want a description of the wound. I want to know if there's any blood loss. I want a description of that blood loss. You guys can estimate, it's about 500 mLs, that's 1,000 mLs, and there are references that you can look up online to do this, or just describe how big the puddle was. Or if it's a vaginal bleeder, how many pads have you gone through in the last 24 hours? If they said, I've gone through a box this morning,
that's not good.
No. And that's very different than, I've only gone through 2 pads today, right? Very different from bleeding. So we need to know blood loss. We talked about pictures being included in the report, but saying like there's severe damage to the car, there is a greater than a foot of intrusion on the passenger side, the A-pillars ripped off, there's starring on the windshield, the airbags went off. Like that type of description is very, very important to us. Oftentimes when we're talking about these pre-hospital activations and traumas, we need to know like how fast the vehicle is going. And oftentimes you don't know that, right? But documenting, we are on this road, the speed limit is this is a highway at 70 miles an hour, is different than, this is
it's a backcountry gravel road.
Backcountry gravel road, which is going to be...
Well, actually it might be faster.
It's faster, right? It's a school zone.
It's 45 to 50 versus this is a neighborhood and speed limits are 25, right? And grandma lost control because a bee flew in the window and she went up onto the lawn. That's a very different presentation.
You've been on that one.
So documenting, there's a lot of things that are based upon the situation of what we want to document in there. Strokes last known well is super important, obviously, because that's going to determine what type of interventions we can do for that patient, whether that's medications, TPA, TNK.
Thrombectomy.
Thrombectomy being the big one now.
And that's not the patient's last known well for themselves. That's family last known well.
Well, I think that probably back to the software standpoint, when you choose a provider impression, the other questions that Mobile Touch is going to ask you are based upon your provider impression. So we see too many clinicians probably abuse unknown medical.
The problem is that when I select stroke or trauma, it gives me all these extra red boxes, and I don't want to take the time to do them, right? And that's not right.
They're there for a reason. They're there to help you in making sure that you document appropriately.
And guide the questions you're asking patients or bystanders to see what happened.
Yeah, absolutely. So stroke is one of those examples. It's going to force you to document a last time known well. It's going to ask you whether the stroke symptoms resolved or not and when they resolve. So again, choosing that provider impression, not just going with the generic one, is really kind of vital. And again, that's even a data point that we look at. We run that report actually monthly to show what provider impressions we're seeing out there. Are we seeing a trend in strokes? Is that something we need to look at as a system? So those items are important.
And a lot of our patients have pain, right? We want to know what type of pain, where the pain's at, the severity of the pain, and then what interventions are we doing in the field for that, which is going to be 9 times out of 10 narcotics, right? And documenting that we gave the narcotic, how much we gave, and then do we have improvement in the pain? Because if they didn't have an improvement in the pain, we're going to go on to the next step. We're going to redose that narcotic, maybe try a different medication to help provide relief for that patient's pain.
Going back to what you said, though, when we document pain and location of pain, are we following OPQRST? Are we following sample? And a lot of times we're not. I mean, It's one thing to document that the patient had pain, but where was it radiating, with severity, quality, and we're missing that. And that's going back to basics.
Correct.
Basics 101. We need to be utilizing OPQRSTs.
And the reason for that is if someone has chest pain, pressure versus tearing is going to send me down two separate paths. Both cardiac.
Is it a tear? What do we have?
Exactly. So the quality of that pain is definitely an improvement and is going to decide whether or not I even give certain medications to those patients.
And you are using your experience there, but that should also be driving the EMS care in that we should be taking, when they tell us, stabbing, tearing, ripping, right? That immediately should take.
We should shift.
Oh,
That's red flags, and then we should do a shift in our care. And
even
where's
if-
the closest surgeon?
Even where's the closest surgeon, right? Because they're dissecting, right? Or even if they're STEMI there, right?
Yep.
Now I have to hold my Ticagrelor or my Brilinta, or hold my heparin, right?
Absolutely.
And
Even aspirin.
And even aspirin. Yeah, good point. Yeah.
One of the problems I have with pain is that almost every single time I ask a patient, what's your pain scale? 0 being the no pain, 10 being the worst
It's
pain
10.
you've ever experienced. How many times is it 10 or higher?
Yeah.
Right?
Oh, it's at least a 15.
Right, but they walk to your stretcher. This has been a chronic back pain they've had for weeks. Oh, it's a 10. This is the worst pain ever. This has been going on for
So one
months.
of the best things I've heard in a long time was about 3 months ago, and I'm going to give him the credit. Anton at Geauga ER told a patient, "Does it feel like bear ripping arms from body?" That's a 10. Like, I like that. So I've used it. It works. No, it's not probably a 10. Right.
So I think you could try to get them to qualify it a little bit more in detail. But then I've also used, I was taught a few years ago, someone used the term, they said, the patient's stated pain is a 10 out of 10, but I put in quotations in my narrative, patient's demeanor and actions do not match their stated pain scale, right? They're talking to you in full sentences, they're ambulating, they're walking, they're showing no signs of distress. So you're putting down what they stated their pain scale is, but I'm qualifying that with another statement that they're really not showing those signs of pain.
And we also have the Oucher scale. We have 1 Baker's if we want to refer to them, and child or somebody, even an adult, pick the smiley face.
Yeah.
It's just that easy. I mean, and if the mid smiley face, but it's a 10.
And the reason I bring that up is because when you document 10 out of 10 pain, what's the first thing you're going to say when you read that chart? Are you going to look up to the event log and to look for something in particular?
Narcotics.
Yeah.
Right. Are you treating that pain?
You're doing
and if
some
you're
biopic.
not, then fine. That's fine. Okay. Just document why you're not going to treat that pain.
10 out of 10 abdominal pain, patient with arms above their head, FaceTiming.
Yeah.
Tells me all I need to know.
Live streaming.
But then also, if anybody with pain from here to here is a cardiac until I rule it out.
Also true.
Of age,
Yep.
and then any younger female of childbearing age with abdominal pain is a ectopic pregnancy until I rule that out. So, red flags.
Yep.
I want to touch on one other thing about importing before we move too far off of that subject. When we have these great tools, right? So 15, 20 years ago when we started this, we weren't able to import data from anything into anything. And now we've gotten vital signs. We've got non-invasive blood pressure. Now we've got temperature probes. The other newest tool is probably going to be the capnography. So you'll notice that your capnography value will import into Health EMS. What you won't see is the capnography waveform. So think of it this way, just like your EKGs, we can't put the entire 20-minute case of your EKG tracing into a PCR. He's not going to want to read it anyway. So we want to mark that when there are events that are important, we want that in the chart. So just the same as your EKGs, we have certain things already built in the software. Your apnea alarm is going to grab a 10-second, what we call a snippet of your EKG. But most importantly, especially when we talk about end-tidal capnography, is if you hit the print button, that tells the monitor to grab a snapshot of what's going on with your patient. It's going to grab a set of vital signs and grab your EKG, and it's going to grab that capnography waveform and import it in your monitor. So what we've been talking about at the Institute is, especially if you're intubations, after you've confirmed your tube is good, hit print. Grab that nice, beautiful capnography waveform showing the value, showing that you've got a good tube. When you get to the ER, hit it again. You're going to have to hit it twice. Hit it once, it starts spitting out the paper. Hit a second time, it stops the paper. But it's going to grab that ticking 10-second snippet. Now you've confirmed your tube in the field, confirmed your tube at the arrival of the hospital. Now you can go into transition care.
And anytime you move the patient in between, it's certainly best practice. You just toggle that real quick.
Absolutely.
Now you can see throughout.
You can see and you can
continuum.
prove to anyone that can review the
Correct.
chart that tube's in the right place.
Correct.
Or a patient's alive during time of transfer.
Also, yes.
Right. That capnography waveform is huge in that ROSC. And, it's something that.
Just one thing I cannot
use.
stress enough is that we need to be treating patients, not monitors. Just always, always, always keep an eye on the patient. If it's not meeting your expectations as what the monitor's showing you, maybe the monitor's lying to you.
Yep.
So just always treat that patient, especially in the case of like a CO poisoning. I mean, I might have 100% pulse oximetry with a patient that just looks like dog crap.
Right.
Don't believe it, and wait for the alarm on the machine that's going to tell you your what capnography levels are at and all that, and then it's going to start flashing over CO, and it's going to give me a high number. Then think about that. I mean, then go to CPAP, right? Blow some of that off.
That's what differentiates a technician from a clinician.
Correct.
Right? And that's what we should be striving for. And the state has kind of started that process for us because we're no longer emergency medical technician, paramedic, or paramedics, and we're supposed to be working towards that clinician mindset. So I take all of these variables and I synthesize them for myself to optimize my patient care. All right, what else? What have we missed on here? Signatures. Oh, signatures.
I'm not that famous yet. You want my signature?
The one signature box that just bothers the snot out of me because I know it gets inappropriate.
Patient signature?
No, actually, it doesn't bother me. At least in my house, they do an okay job with that. Is the electronic signature for controlled waste. And that's a little bit problematic in health EMS.
So
Do you want to talk to that? Or?
well, I guess tell me the problem. Let me see what you feel is not adequate.
So the state of Ohio requires multiple levels of authentication for the waste of a controlled substance with an electronic signature. And in the hospital, that works fine because the nurse is doing a PIN or a password and badging in or swiping in or, retinal scan, whatever they're doing that week, right? Thumbprint scanner. They've got, a two-level authentication, which we're lacking here. So by letter of the law, we can sign electronically for administration, but the electronic signature by itself on the chart is inadequate. And that's why in the drug box
It's a sign.
is a wet ink signature. This is a wet ink signature form. Now, does it hurt if you also sign it doesn't hurt, but you must have, and that's the take-home point here, is you must have that wet ink signature to be above board and be tied off and legal as health EMS currently stands. If we put a thumbprint reader on here, maybe it will, in the future, make that valid.
Right. So I kind of want to address that on two issues. Number
Sure.
one is how often. So you write a chart, right? Do you have another partner in the back of the truck with you while you guys are on your way to the hospital?
Generally,
or are you
no.
by yourself?
Depends on
He
the
kicks
call.
them out.
Okay. If someone else provides a medication, they actually administer it. Do you have them sign the PCR?
They should.
Right, they're supposed to. So how about if Board of Pharmacy says anyone who administers a medication should sign that chart? So if you have you're lucky enough to have another clinician in the back of the truck with you, if they actually push a med, you want to make sure they sign in that technician 2 slot, right? To further what you're talking about, yes, correct. There's no authentication for that second signature. That's why we fill out the wet ink. That gets sent to pharmacy. We still are collecting those signatures, doing our due diligence in the ePCR program. And then our pharmacies, not only UH pharmacies, but Cleveland Clinic and our other surrounding hospitals, because we use this exchanger program where we're sending them this document electronically, a lot of them have access to that right in the pharmacy. So they'll take that wet ink piece of paper and they'll take your PCR, they'll print it off or they'll match it up, and then they have that on file for any pharmacy inspections that they have. So it is really important to think about getting that extra signature. Obviously, your wastage, you need to have somebody else witness for you too.
Do we even want to dive on that and on the wasting? And
I just think one of the best points to remember is try to have somebody unbiased off your crew if possible sign for that waste. I love having an RN. Even if the doc's sitting there not doing anything, I'll have the doc sign my witnessed waste. I mean, don't come to them and say, I've already wasted this.
You've got a clinical pharmacist in the ED.
Yeah.
They'll be very happy to do that.
Absolutely, yeah.
So, and they're absolutely happy to do that. And it's always great because then they could change the box out with me real quick too. But I would try to stay away from having your crew sign it if possible. Just like I try to not have my crew sign in a witness box if possible.
Right.
I'd rather have a family member or a sheriff or somebody else who's unbiased to the report.
Although legally okay in the state of Ohio.
Legally okay.
It doesn't even have to be somebody that would normally have access to that drug. It could be an EMT an EMT level.
As long as it's
provider.
witnessed waste.
Correct. However, to your point, is that best practice? No, that kind of looks suspicious. And, if it happens once in a blue moon, it happens once in a blue moon. But
And if it's a narcotic, which is when we need the signatures, you have to exchange that box, hopefully. So you're going to the pharmacy anyways. Does that mean you wait and have the pharmacist waste it with you? Why not? I mean, it doesn't have to be sealed. Then put a yellow tag on it, go to the hospital, then red tag it with the pharmacist.
And from the software standpoint, anytime a narcotic is administered, it flags you to ask you to get that wasted signature. So if you drop 500, you provide all 500 of ketamine, it's still going to say, hey, I need this wasted signature.
Did you waste anything? Yeah.
So if you go down there and you just put in waste amount 0 milligrams, then you don't have to get that signature anymore. I just want to make sure everyone knows that you don't have to do it as long as you put the 0 in there for the amount that was wasted.
And I think we touched earlier on treatments, but that same thing goes for medications, is don't just put that medication administration in your narrative, also add that event log. I think our discussion was specifically about treatment items, so things we did, IVs we started. But you can't run a report on a narrative.
Right.
You can only run a report on, add items, if you will.
Right, and we've tried to be really careful about adding certain medications we can put in at a standardized dosage, right? So we have default dosages, let's say nitroglycerin at 0.4, right? But we try to stay away from it because we want to make sure that there are a lot of weight-based dependent or pediatric meds. So again, it's really important to look at your documentation before you export it and make sure that, let's say, normally we have it set up as an IV administration, but you were on full rest and you had an IO on, right? So you want to make sure you correct that, especially the dosage and the route. Those are the two things I see is sometimes you accept the default and no one catches it, that it was actually done differently and doesn't get corrected. So again, reread your report before you export it.
One of the mistake that I make is I go to, let's say that my default for my EMR is 0.5 milligrams of Dilaudid, but I feel the patient needs 1. I'll go in there and change it to 1, and somehow I'm now ordering 15. So luckily I have pharmacists that catch my mistake, and
we're all human.
Exactly.
Everybody makes
or
mistakes.
0.15.
Yeah. So also verify that you don't have just a documentation error, that you actually, oh crap, I didn't mean to give 11 or 10 or whatever. Go back and correct that when you review your
I just had that the other day with somebody that gave something and they put 10,000 and they didn't mean to, and I flagged it. And I said, yeah, I think you meant this, right? Yeah, let's fix that.
Yeah.
And unit of measure is another point that needs to be discussed there. As I had a case just the other day. Somebody I gave a milliliter of Versed. It's like, cool. Now I know what's in your box, but the reader, whoever's reading this has absolutely no idea.
I don't know what concentration
is. Is that 2 milligrams? Is that 10 milligrams? Is that 100? Nobody,
Yep.
So, that got sent back to QA. Just make that in milligrams.
As far as QA is concerned, though, we have to be receptive to that and not take it on a chip on the shoulder. We have to be able to take that and grow from that. That's not a slap in unless you blatantly do something dumb. Then I might come over and slap you first. But
it's constructive feedback saying, hey, I noticed in your documentation that this probably isn't correct. Correct it for this one so we have accurate documentation. And you should, by the way, realize that, that might be a mistake I might make in the future. I should review that, make sure I don't make that mistake again.
Absolutely.
And that's all what this is we want to provide safe care to those patients.
I think years and years ago, there were people that were too afraid of getting in trouble because they couldn't differentiate that, I'm getting in trouble versus this is quality improvement, this is quality assurance, right? Asking a question, how can we make this better, is very, very different than you F this up and you're a terrible provider. Those are two completely different things.
Yeah.
And
probably different conversations with different people. You get pulled into the chief's office, assistant chief's office.
20 at a time, right?
Yeah.
Well, Bob, I have 5 bosses.
5, Bob?
Years and years and years ago, we were talking a little bit about kind of flavoring the narrative using appropriate adjectives to help bolster the picture for the reader, but that can be overdone in what I affectionately call fluffing the PCRs. We had a case. We first put midazolam in the drug box. We had diazepam in there, we had Valium in there, and we had just introduced intranasal. We had just introduced the intranasal Versed in. And at that time, the starting dose was 10 milligrams. It was like, hi, my name's Sky. I'm a paramedic. Oh, you're seizing. Here's 10 milligrams. And, in my house, we had about a third of our patient population had some negative hemodynamic or some negative respiratory consequence to that. I mean, it's Versed. It can happen. It's generally a fine drug, but in that particular case, we were in a very specific patient population. Those were multi-comorbidity, polypharmacy, debilitated patients, which is who my agency deals with. We were having some bad outcomes. And we would get reports back that, said, there was some, mild hypotension, right? And then you would see a 1.5 liter bolus that's substantial, right? That's substantial, that's not mild by a lot. Or, there was some slight respiratory depression, but OPA and BVM were checked on the same report. It's just like, look, in that particular case, and by the way, if you do the math, if you take the intranasal dosing of 0.2 milligrams per kilogram, anybody at this table, you're over 10 milligrams. Yeah. Mathematically, it was a fine number, right? It was just in that population, we were having some bad outcomes. And that's why the protocol is what it is today, or part of the reason it is what it is today. But there was that tendency. You could see it. It was blatantly obvious. It's like you guys just didn't want to get in trouble. Yet this was something that we were advocating from a protocol standpoint, and it actually took probably longer than it needed to get resolved and get pushed. We actually in that case we learned backwards, right? We learned from the field provider back to medical control. It's like, guys, this isn't working, right? So it's. Be clear, right? Do you know the outcome of every medication administration to every patient? Sometimes they get it for the first time. How does somebody know that they're going to have an allergy, a sensitivity, or a reaction?
Think how much worse it would be, though, if we try to falsify something because we're afraid that we might have done something wrong. It's bad all over the place, and I think it would come
worst thing you could do.
Way much better if I just come clean. Hey, doc, this happened, and this is why it happened. I think that's going to go over much, much easier than they're going to find out. Somebody is going to find out through that chain that we keep talking about. I mean, the pharmacist reviews, you review, the departments are reviewing, doctors are reviewing, and it's going to be something's odd here.
If you make a mistake, it's not a mistake. If there's an error or misstep or whatever, and you say, "Hey, I did this," I'm like, "Man, this is the 5th person this month that's made."
Where is this error coming from?
Yeah, exactly.
And it's been found out already that we've had errors with ResponSoft, and we fixed them. We fixed them, and that happens through patient care error. And it's hey, this happened. We need to fix this. So try not to cover something up, though, because when it's found out, it's way worse. Not only for you, I could care less at that point. It's way worse for the patient.
And again, document that. Yeah. Document whatever it was that happened. Oh, I meant to give this medication, but gave this medication. Because we need to know that in the emergency department to see what meds were given, so that way I don't even make the problem even worse, or I can address whatever error was made.
I think that's what's great about, I've been in my role with University Hospitals for probably about 5 or 6 years now, I believe. And let me tell you, in reading the amount of charts I do and reading the amount of charts that we all do, we find mistakes. We find them often. A lot of times they are self-identified. Sometimes we just discover them. And I can count on probably one hand the times that anything has resulted in a punitive measure. University Hospitals EMS Institute is amazing at getting the education to the people that need it, and this is what we use to identify who needs it. It's okay to make mistakes, document them, get them in front of us so that we can go out and get you the education you need to ensure that mistake doesn't happen again or to happen to anyone else.
And you're human. You're going to make mistakes.
Absolutely.
I make mistakes. We all make mistakes.
Like you alluded to, I mean, we are a teaching hospital. I mean, you and I know that. Especially, I mean, we constantly are teaching con eds. I'm sure you do con eds, and the paramedic program. Everywhere else, we are a teaching hospital, and people make mistakes. We're human. So I forgot to document. It wasn't me, but somebody forgot to document. We cleared the airway the other day on a patient. Like I said earlier, and it won't happen again.
Likewise, I think the medical directors and all the administrative staff as a whole were very good about kind of swallowing that pride and being, hey, we can do better in the directive as well, all right? we're in the process. You, of course, have seen it. Well, you would have seen it the other night as well. Some of the changes we're doing in the ACS protocol. It's been the way it is for a long time, but it took an error to be like, we could present this better. I mean, we could have prevented or help certainly cleaned up that one particular case, and we've gone back to the drawing board. Just essentially because of one case. And it wasn't a sentinel event and somebody died. It was just a, cardiology be like, why'd you guys do this? And they're like, we didn't present it exactly the way we needed to for the provider to absorb it. And we go back to the drawing board.
I mean, as lame as it sounds, we're still practicing medicine together, and we're growing.
I mean, that's part of what makes us really cool organization to be aligned with. So.
Absolutely.